everyone, welcome back to KSSK Cure CMD chat. This episode we are going to be talking about acute care. Sophie, I do believe you have a little bit of experience with acute care?
Yeah, I got a spinal fusion surgery to aid my spine issues, scoliosis, lordosis. Basically, they just inserted 2 titanium rods so that I could sit up straighter, and it's helped my posture. I'm really glad I got it. We did have to talk to my pulmonologist about anesthesia and stuff, trying to make sure that I would be safe, respiratory wise. I was a little nervous, but I felt like I was in good hands. I felt generally safe. It wasn't painful for me at all, except for when I got lifted up, because sometimes it would hurt my tailbone. But we solved that. We figured out how to give it support and everything. And I got a dog out of that. They were
nice!
Yeah, period. I got a dog.
That actually makes me feel better hearing it coming from someone my age.
Don't expect it. I don't know. Don't expect it. Your parents might watch this and be like, we're not getting her a dog, so.
No, I meant the surgery.
Oh, okay.
Because I'm everyone is older than me that I've heard it from, and they're like, you'll be fine.
I don't think it's anything to worry about. I mean, you seem like you're in about the same shape as I am. But yeah, if you're gonna get one, that's just my experience.
I'm now excited to learn the delicious fine details.
Right, the scientific stuff.
On to our interview.
Hello, Dr. Graham and Dr. Perez. It's really great to have you back. So for those who haven't yet watched our episode about ventilation, could you introduce yourselves again?
I'm Rob Graham. I'm an intensive care doctor at Boston Children's Hospital. I also run our home ventilator program and work with young adults like yourselves and children and older adults around keeping you out of the hospital and keeping you at home.
I'm Geovanny Perez. I go by Paco. I'm a pediatric pulmonologist, and I've been involved in the care of patients with neuromuscular disorders for probably around 7 years.
So today we're going to talk about acute care. To get us started, can you explain what exactly acute care is?
Paco and I are always happy to see you or your friends as in clinic. That's sort of routine care, or when you go to see your regular doctor, those types of things. When we think of acute care, you're in the hospital. You're in the emergency room, you're in the operating room, you're in the intensive care. So it's coming in for something that's either unplanned or a planned surgery for that matter. But it could be everything from you're in a car accident, that's acute care. You've got pneumonia, that's acute care, any of those types of things.
Speaking of planned surgeries, I am actually going to get my wisdom teeth out. The biggest debate was about what are they going to do anesthesia-wise? Am I going to be put under completely? Are they just going to give me the anesthesia, but I'm going to stay awake during the surgery? So I didn't know how different my needs were from other people. So would you mind helping explain that a bit better? Someone with CMD, how they have different needs and different risks.
That's actually a very, very, very good question. And I think that's when it's very important that your providers communicate very well between your outpatient doctors and your inpatient doctors, between the surgeons, the anesthesiologists, and the ICU doctors. So depending on your lung function, right? So when you go to your pulmonologist, they will ask you to blow through that machine and look at your FVC or looking at the different pulmonary function testing clinic. That will give us an idea to figure out how good are your muscles and your respiratory reserve. And based on that is when we decide what might potentially happen after the surgery. Ideally, you try to avoid as much as you can general anesthesia for any elective procedure, right? Remember that when you have general anesthesia and you're completely knocked down, your muscles they become very, very, very weak. So it might take you some time, and if you're already somebody that is weak, it might take even extra time or extra effort to try to go back to your previous baseline. So sometimes what we recommend, for instance, is if you're going to have a procedure where you need to have a lot of sedation, maybe instead of just taking the tube out in somebody that is on a BiPAP, just put them back on the BiPAP right away. Or sometimes in somebody that is not on the BiPAP, that is very close based on that lung function, maybe you just do that. And again, it depends also how long the procedure will be, if there is any issues with oral secretions. So if you're going to the dentist, and remember that your muscles that control swallowing can be affected sometimes. So if there is somebody that might be having issues controlling the secretions, if you're going to the dentist, we're a little bit worried that they might be an aspiration event. But the key thing is trying to communicate with your surgeon, dentist, and then with the anesthesiologist that is going to be there at that time to try to have a plan of this is plan A, but if there is something that doesn't go the way that we want it, what will be plan B? How we're going to communicate this to the ICU doctor or the hospital or the doctor that is covering that night to make sure that we do like your airway clearance, your cough assist, your BiPAP, and so on.
It's anticipating problems. Your standard dental office or orthodontist office, when they're taking out wisdom teeth, they're not going to monitor carbon dioxide. They're going to put on, the oxygen monitor on your finger, and that's it. But with someone with CMD, we usually recommend that they have carbon dioxide monitoring while they're actually having any sedation. It's also not unusual for people with CMD not to be able to open their mouths as wide as the orthodontist or the dentist thinks that they should. So that's something they have to think about in terms of, can they do what they think they want to do? And as Paco was saying, if they can't, what's their plan B? And then the other thing, I think, Kierra, you asked about it, what type of sedation should you get? There's no magic recipe. I think it's being cautious. It's important, though, a lot of people will talk about conscious sedation, that, if you're getting sedated, you're already, lowering your level of consciousness. And with that, your muscles are affected. And so it's probably best to think of it as procedural sedation, not conscious sedation, because if you're conscious enough to feel it, then you're probably not getting much sedation. And you don't want to sort of creep into that anesthesia and without all the extra things that from a safety perspective.
I've actually experienced a lot of those things that you mentioned. When I got spinal fusion, like summer of 5th grade, they had to work with my pulmonologist about the logistics of the anesthesia. And actually, whenever I got my teeth pulled, my mouth was always really small, so it was hard to open. They have to use the clamp thing. It's kind of annoying.
I thought that was just a me thing.
No.
I didn't know that was actually common for people who had CMD.
Yeah, I think we all have generally small mouths or something.
What happens if you are actually in a bad accident and you have to go to the emergency room? How do they take care of you then if it's planned? Is it recommended that you have something on you that tells the doctor what you need? Is there any way that they can talk to someone quickly?
Everyone does it a little bit differently, but yeah, presumably you're going to be with someone, but that person may be in the accident with you and not be able to respond either. And if you have a power chair, it's not a bad thing to have even just a one page, like, this is my diagnosis, this is who to call, and here's a website or something like that. Some people carry around, thumb drives with their medical information that's tucked in there. The key is also just to reach out, have some way they can reach out to whoever your primary team is, who knows you. Because, I can guarantee that no matter where you show up, they're not going to know collagen 6, and they're not going to know myristoyl negative, CMD or you name it. And you want them not only to do the right thing, but you want them not to do the wrong thing.
Nowadays, you girls are obviously way younger than both of us. So with technology, I don't know what kind of phone do you have. The iPhone has stuff where you can put all of your medical information, and even in the case of an emergency, any provider can access to it. You can also have a medical bracelet. You've seen people they take something, medications to make the blood thinner. So you can have something like that, or a necklace with some information, or who to call. There are actually now even companies where you can keep your own records on a website. You get to the emergency room and this is my medical records are on this website. So everything can be uploaded there. Now in this era of technology, I think that is going to be very helpful. But everybody's different, so you ideally should have a plan.
What are the key things we should inform a healthcare team about CMD prior to having a procedure that would require some sort of sedation?
Yeah, what do you need for your breathing support normally?
Right.
And then just help them anticipate that you may need more afterwards, in terms of the weakness and secretion clearance, all of that you may need after a procedure or after any sort of sedation and those types of issues. It's also helpful to say, I'm not like someone else with a different type of muscular dystrophy. As much as information as you can give them about your specific type of CMD, that's helpful. It's yes, my heart's involved. No, my heart's not involved. I have a very restrictive, my chest is small and my back is a little curved, or, what are the other things, that you have to sort of think about for your specific type of muscular?
Something that it will be helpful is to, I don't know what kind of like setup you have for your clinic. You might have an interdisciplinary clinic where you have like four, 5 or 6 different subspecialties in the same day, or you might seeing like your pulmonologist one day, your cardiologist another day, your neurologist another day. But ideally, you should probably have some kind of like a summary of a document where you can say like, this is what I have. These are like the issues, as Rob was saying. Is there any issue with the heart? It's very important, especially you're going to have like kind of like a more like major surgery like scoliosis. They need to figure out how much fluids or volume they give you and so on. So maybe having that communication on a paper, kind of like a brief 1-page summary of this is what I have, this is my lung function, these are kind of like the equipment that I use, such as my BiPAP, the cuff assist. And again, I think that it has to have like a fluid communication. I don't think it's just like a one-time, like, here I am, this is what I have. I find a lot, very often, that it's very helpful to just make a quick phone call and say, hey, these are the issues and these are the concerns that we have, and try to have a fluid communication among providers. The key thing is to prevent any complications and try to be ahead of the curve. If we think that this might happen, this is what we already planned for this, we already planned this. If we're needing oxygen, we plan to do this. If the CO2 levels are high, we're already planning to do this. So we try to prevent any further complications from any procedure.
And one of the reasons Cure CMD's pulled together guidelines is just for this, exactly this, is that it's for you guys, but honestly, it's probably more, you probably know more about this than most of the doctors you're going to interact with. And so it's as much refer them to the Cure CMD guidelines, honestly. If someone were to call 911, you want to know who's going to show up. And you could say, you go to your local police or your fire department, or whoever's going to be your first responder, even at home, and say, by the way, I live here. If there's a problem, when you show up, this is who I am. So it's both at home and at travel, and sort of knowing, and even then going the next step and say, okay, where would they take me? Are they going to take me to the hospital that knows me, or are they going to take me to a hospital that doesn't know me? In which case, you've got to sort of anticipate that.
I haven't done it here in Buffalo, but in DC, you can actually get the 911 dispatcher to record some of your information. So your phone number, your address, and your diagnosis. So anytime that a parent or somebody will come from that phone number from home, then at least the dispatcher has some information on what is going on. So it could potentially make a difference of like what kind of like people is going to your house. Is just going to be the regular fire truck, or they might know like, oh, somebody's on with these kind of devices or a ventilator at home, so we want to send somebody else. And they might even have a plan about like to what hospital they can take you, because there are certain regulations. But it's a really true emergency, usually they will take you to the closest hospital, regardless of what you have or where you live, right? That's kind of like the main thing, get you to the hospital as soon as they can. But if maybe like the closest hospital does not have the right setup for you, they might be losing some precious time. So they might need to plan to like, maybe let's get you to the children's hospital, even if it's a little bit farther than the one that is closest to your house.
I do have to admit, though, that sometimes we don't like to listen to each other. So the more you speak up or have your family speak up, the better.
We've been talking about what happens in the hospital and what we should do before we have to go to the hospital. But what about after we're able to be set free back into the world with the discharge and the transition back to outpatient care? I'm going to add on to that one, actually. What's the difference between inpatient and outpatient care? And how do you transition from one to the other?
In general, inpatient care is the hospital, and outpatient care, it can be either your house or it could be your regular outpatient clinical visits, like where you go to your neurologist, pulmonologist, and so on. So there might be some variations of what happens between the hospital and then what happens when you're outside of the hospital, when you're discharged from the hospital. Depending on the setting and depending on where you're admitted, if you go to the ICU, what we usually want to see is that from the ICU, you go to the general floor. So you go to the general ward you're not don't have a lot of monitoring, then once you're very stable and close to your baseline, then you go home. Something that I think that is very important to understand is that a lot of times hospitals will use the discharge criteria, right? That means that you are well enough to leave the hospital, but that does not mean that you're back to your baseline. That it doesn't mean that you're completely back to normal. It just means that maybe we can continue care at home, provided that you have, your nurses, your parents, or somebody else that is going to walk you through the whole process until you're back to baseline. So oftentimes after you leave the hospital, you might need to use maybe increase the number of therapies that you do. So if your baseline was doing nothing, you might need to be doing maybe therapies maybe 4 or 5 times per day. Ideally, we have certain thresholds. So you might need to use your BiPAP a little bit longer. Remember, you were mentioning that sometimes you feel tired, so sometimes you use the BiPAP during the day. So you're recovering, and we think that you're going in the right direction. What we might say is that, maybe you need to use your BiPAP a little bit longer than you used to until you're fully back to your baseline.
Every circumstance that you come into the hospital for is a little different. So if you come in for a pneumonia, it's going to be different than if you come in for a planned surgery. It's really a question of how much reserve do you have. And then, it's a safety to get home. It's one of the criteria. And how much extra support can you get at home? Is it worse being in the hospital than it is being at home? After surgeries, there's a lot of things. Like, you don't want to be in pain because pain is not comfortable.
Pain sucks.
You can't do your therapy. You can't breathe. You don't want to breathe as well. You may not want to eat. So you want to stay in front of the pain treatment. But then that also affects sometimes maybe you need a little more breathing support because of that, or maybe it slows down, how frequently you're going to the bathroom. And if you can't keep anything down and you can't keep your nutrition and calories up, that, it all sort of snowballs. So you kind of have to look at everything in terms of your comfort, your breathing, nutrition. You don't want to leave the hospital after your spine, surgery until your chairs are adapted. And maybe you want to go to rehab if you're a little deconditioned. If you've been in the hospital for a long time for pneumonia or something like that, or after a big surgery, you may think about going to rehab because the therapies you get at home are going to be far less than you would get in an inpatient rehab. There are lots of options, but everyone sort of appreciates sometimes it's better just from a mental health perspective to get out of the hospital.
Thank you so much for talking with us today. I know this is a stressful topic for a lot of people who feel like they could be in danger in emergency situations, but this will help us be more prepared, giving us some important tools.
Yeah, I think that is very, very, very important what you're doing. I mean, learning about your disease, and at some point you're young adults, and as Rob said, you need to advocate by yourselves. When you go to the hospital yourself with your parents, knowing the disease and what to do and speak up, I think that is very, very important.
Yeah, educating others about yourselves and your condition. I think that's the way to go.
This actually makes me feel better now. I'm never gonna go to the hospital because I don't wanna, but now that I have a plan, I'm kind of nice. Thank you for being able to spend time with us today.
Thank you for inviting us.
It was a pleasure.
Bye.
For more ways to stay connected, download the CMD mobile app and sign up for the newsletter. Here is a link to the CMD Pulmonary Guide, which is very interesting. And if you have questions, email us at breathe@curecmd.org. And wait, before you go, be sure to like and subscribe. Add your comments below to keep the conversation going. Thanks again for watching. Bye!